for about 17 or 18 years. So we've got a lot of experience in this. And indeed, in our hospital, we are writing the new edition of the UK National Early Warning Score, which has also been adopted by a number of other countries. So we've got some expertise in this area. And our hospital often does quite well in British awards and league tables in terms of safety and mortality and all that kind of thing. But nonetheless, I'm going to tell you some stories from our hospital about where we get it wrong, and maybe you can help us not get it wrong. And as a matter of interest and a matter of information, declaration of interest, we are also part of International Society of Rapid Response Systems and Medical Emergency Teams, which is having its annual meeting next month, 5 weeks' time. And if you are interested in learning about this really from a panel of the world's experts, this is the place to go, to Chicago in 5 weeks' time. And some of us will be there too. Okay, so, oops. So I'm going to tell you about a sort of archetypal case from our hospital. It reflects some of the things that Cors mentioned already. So this is a story of a man who was 91 years old, but he was doing okay at home. He was living at home. He had to get around by holding onto the furniture a little bit. He had some cognitive problems that had developed in recent years, but was living a contented life. And then he fell and broke his hip. So he came to the emergency department and then through to the surgical assessment unit, and within 24 hours was in the operating theatre. And because there was a recognition that he was a high-risk case, he went for post-operative care in the ICU. 24 hours later, on the ICU, he's assessed as being ready to go to the ward, relatively complication-free. He goes to the ward on the Saturday afternoon, he's there on the Sunday, but by Monday, he has a cardiac arrest. And in fact, he dies. So I'm going to fill in some of the details of that, but so in quite a short space of time, he goes from functioning pretty well at home to being dead. And it may be that the systems that we're talking about here could have helped with some of that. Okay, so I've mentioned some of his background. He had some cognitive deficits, as I mentioned. He had some cardiovascular pathology. He had a bit of gastritis, which probably doesn't matter too much. And he'd already had his knees replaced, and then he had his hip fixed on this day as well. So what's good about all that information? That's non-volatile data. We know what those things mean. We know that around 5% of hip fractures will die in the next month. We know that if you're 91 years old, the probability that you'll die before getting to 92, well, is about 20%. So these are all factors that are known in a system and could be added into risk analyses. And of course, this man also had some long-term conditions and frailties and so on. So all that could be calculated and made manifest. And certainly some of the people looking after him were aware of those things, but not everyone, and that was probably important. So, I told you, he went to the theatre on the Friday. His surgery was pretty straightforward. He only had a litre of fluid given, which tells you that he didn't lose much blood. And he was in and out of theatre and into the ITU in about an hour and a half. He had some bloods taken, a whole batch of bloods, but they included these, which were to look at his kidney function. And he had a bit more fluid in the ICU, had a sort of moderate positive fluid balance to midnight, but all going well. And then in the morning, this is the routine thing that is done. He has some bloods taken first thing in the morning so that when the day team come in, they can have a look at those and use that as part of the assessment of progress. And these values have all increased a bit from the ones the day before, but perhaps not too much to worry anybody. But actually the issue is that although those bloods are taken, he is seen at 8:59, and the bloods at that point aren't available to the medical team. They haven't come through yet. But a doctor sees him and says, well, he's looking okay. He can go to the ward. We knew that there had been some increase in his inflammatory markers, which might also be infection. So the ward should keep an eye on signs of sepsis, which would be entirely reasonable after an operation like this. But he's ready to go. So the decision is that he gets de-escalated in terms of his monitoring, and he's ready to go. And these are his vital signs, first at 8 o'clock and then a few hours later. So if you look down the column that starts with 8 o'clock in the morning, you can see, well, for one, that they've said that his respiratory rate is 37, and that's taken from the electronic record. And that sort of shows that these systems can sometimes fail us, even in the ICU, because I think it's almost certain that his respiratory rate was not 37. But nonetheless, that's what's on the record. And all the observations are okay, the other ones. 4 hours later, he has some more observations done, and there's a bit of a change. For example, you can see that his blood pressure has somewhat dropped. But at this point, the decision has already been made that he goes to the ward, and that doesn't really change anything. And then before he departs, his daughter comes to see him on the ICU and says, "Do you know what? He's not quite himself. He's a bit more confused than he normally is." But then we say, well, he's had an operation, he's an old man, he's already confused, maybe you're exaggerating, let's not worry about that. And even the physiotherapist who sees him just before he's wheeled out of the door says he can't follow commands. When I ask him to lift his arms, or he's not doing that, that's okay. He goes to the ward. So on the ward, it's a very different situation. 1-to-1 on the ICU, and on the ward, it's one nurse for 8 or 10 patients, sometimes even less at night. But nonetheless, he has a couple of observations done at 4 and at 5, and then not till 9:30 in the evening, and then not till 6 a.m. on the Sunday. Then at 10:20 on Sunday morning, they notice that his pulse has gone up. And they do call a doctor, they call a junior doctor. This is our protocol that you call when the signs hit that kind of level. The doctor says, well, he's got atrial fibrillation, that might be part of it, but let's give him a bit of fluid. Not too fast because he's an old man and his heart's not too strong, but let's give him a bit of fluid, see if that helps. Doctor comes in there. Nonetheless, he doesn't get any more done until 4 o'clock in the afternoon. His pulse hasn't changed, as you can see. One more set at 8 o'clock. So nothing much has changed. And by 8 o'clock in the morning on the Monday, hasn't had any observations done overnight. His pulse is still about the same as when the doctor came on the Sunday. So now the more senior doctor that comes in is able to say, well, his observations are stable in the sense that they are the same throughout this period. And they continue to be stable mid-morning. Pulse rate hasn't come down. He's still stable. And then he has a cardiac arrest. And we do some bloods for the first time since he left the ICU, and they now show that his kidney function, which actually was drifting upwards on the Saturday, has drifted up even more. And if we'd taken some more bloods maybe on the Sunday, we could have spotted that. And he has a potassium that's sky high. That might be because he arrested, or might have contributed to his arrest in the first place. And he dies. So if we had time, we could maybe have a discussion about what could be better here. But in the interest of brevity, we'll just sort of skip through these relatively quickly. What we're trying to capture here, or what we should be trying to capture here, is both the non-volatile data, those risk factors that I talked about, the comorbidities, the chronic conditions, and the volatile data, the stuff that can change, like your heart rate, your blood pressure, your oxygen level, your bloods. Those sorts of things are non-volatile data. And those things could be brought together in a good system to update us about levels of risk for patients. And that doesn't happen at the moment. We could have had a system that flagged that hypertension that he got on the ICU on the Saturday lunchtime. We could bring in the use of the soft signs, his daughter saying that he was confused, the physiotherapist saying he doesn't obey commands. We don't really measure consciousness or cognitive function very well. None of us are very good at that. And that could be part of the system. That might have made us rethink the discharge. There was no urgency for him to go out on the Saturday. There were beds available. Clearly the monitoring on the wards was very suboptimal, and although there was one alert when the heart rate went up high, nobody came back to check what had happened as a result of giving the fluid. There was no feedback loop. And indeed, the fact that the bloods were already getting worse on Friday and Saturday in a good system might have provided an automatic alert that they should be rechecked on the Sunday to make sure that things were not getting worse. All of that would be easy, or should be easy, but we failed in this situation.